Buenas tardes, buenas noches a todos. Bienvenidos sean todos ustedes al webinar científico titulado Un nuevo enfoque para el tratamiento de la enfermedad poliquística renal, terapia cetogénica centrada en plantas, la cual será impartida por el doctor Thomas Weimbs. En unos minutos vamos a poder dar inicio. Vamos a esperar unos minutos a que se puedan conectar más personas y podremos dar inicio. Les comento que al finalizar el webinar les daremos todas las pautas para que puedan obtener la constancia de asistencia. Es importante que estén presentes como un mínimo el 50% de la plática para poder hacer válida su constancia. Les repito, para la constancia, toda la información se las voy a brindar hasta el final de la charla. La charla va a estar en inglés. Les sugiero que en la parte de abajo puedan activar los subtítulos. Ustedes pueden modificarlo para poder también compartir mediante el chat las preguntas que vayan teniendo, ¿de acuerdo? Entonces pueden ir dejando sus preguntas conforme va avanzando la charla y yo voy a dar lectura hasta el final de la plática. Les repito, para obtener su constancia de asistencia hasta el final de la charla, voy a compartirles los pasos para que puedan obtenerla y de igual forma es necesario que estén presentes por lo menos el 50% de lo que dure este webinar, ¿de acuerdo? Muy bien, pues entonces llegó el momento de comenzar. Repito, el título del webinar del día de hoy es Un nuevo enfoque en el tratamiento de la enfermedad poliquística renal, terapia cetogénica centrada en plantas. Ok, ya tenemos por aquí al doctor. Hi, Dr. Weimbs.
Hi, Paula.
How are you?
Good, doing well. Thank you for having me.
Thank you. We're pretty good. Thank you. First of all, welcome and thank you for this webinar. I'm going to read your short CV.
Okay.
Les presento al doctor Thomas Weimbs. El doctor Thomas Weimbs es profesor de la Universidad de California en Santa Bárbara, en donde dirige un laboratorio de investigación para la enfermedad poliquística renal, abreviada como PKD por sus siglas en inglés. El doctor realizó su doctorado en la Universidad de Köln en Alemania. Después realizó una investigación postdoctoral en la Universidad de California en San Francisco. Posteriormente comenzó su primer laboratorio de investigación independiente en el Instituto de Investigación Learning de la Clínica Cleveland como profesor asistente. Ahí comenzó a investigar lo que es poliquistosis renal en su primer laboratorio. Para el 2005, el Dr. Weimbs trasladó su laboratorio a California para poder incorporarse al Departamento de Investigación Molecular y así poder estudiar todos los mecanismos subyacentes a la poliquistosis renal con énfasis en el desarrollo de nuevas terapias. La investigación del laboratorio del Dr. Weimbs ha llevado a una mejor comprensión de la poliquistosis renal y ha dado lugar a métodos novedosos para administrar terapias específicamente para los riñones poliquísticos. Algunas de las investigaciones más recientes han llevado al descubrimiento de que las intervenciones dietéticas y los metabolitos naturales ralentizan fuertemente la progresión de la poliquistosis renal, resultado de sus investigaciones en modelos animales. Esto condujo al equipo de Santa Bárbara Nutrients con el objetivo de hacer que estos enfoques estén disponibles para el manejo nutricional de la poliquistosis renal y con ello poder apoyar la salud renal. Sin más preámbulo, esperamos que todos disfruten de esta ponencia y nos vemos más tarde para la ronda de preguntas y respuestas, las cuales pueden ir compartiendo mediante el chat. Dr. Weimbs, we are excited for this webinar. After the talk, we will have Q&As, so I think we can start, please.
Wonderful. Well, thank you so much for having me. It's a great pleasure to be here. And let's start. Good. So, just a second. All right. So, as the screen is coming up, yeah. So my name is Thomas Weimbs. As Paula mentioned, I'm a professor at the University of California in Santa Barbara. I'm also the Chief Scientific Officer at Santa Barbara Nutrients. And I have my disclosures here. So besides being a professor at UCSB, I'm the founder, president, and CSO of Santa Barbara Nutrients. Here's the team at the university, my research lab at UCSB. Most of the work that I will tell you about today was done by Jacob Torres and Sebastian Strubel in my lab, also Nick Holznecht. And just by way of introduction, I'm sure all of you are very familiar with polycystic kidney disease and the most common form of it, autosomal dominant polycystic kidney disease, or ADPKD. I'm just going to call it PKD for short. It is considered the most common life-threatening monogenic disease, affects over 600,000 people in the US and millions worldwide. And that makes it about twice as common, for example, compared to multiple sclerosis, and about 20 times more common than cystic fibrosis. So it's a fairly high impact disease. Clinically, the disease is characterized by, as the name suggests, renal cysts, epithelial-lined renal cysts. There can also be hepatic cysts, pancreatic cysts, intracranial aneurysms can be a problem. Hypertension is very common, and typically kidney function fails in about half of the patients by age 50, which means they need to be, of course, on dialysis or receive a kidney transplantation afterwards. And these polycystic kidneys can get very large, and that's sort of a distinguishing feature from other forms of chronic kidney disease. So in PKD, of course, kidneys grow very large, and these are like two examples that were just taken out of one patient. Of course, at that size, there can be pain is very common in people with PKD. So how does the current treatment or management of PKD look like? And I'm talking about PKD before end-stage renal disease. There's only one approved drug that's called tolvaptan, which only slows the progression, but does not stop the progression or even reverse disease progression. So patients will eventually still progress towards end-stage renal disease. It has significant side effects and toxicities, including liver toxicity. Is a very expensive drug. And is only available to a fraction of the patients in the US, and in many other countries it's even less available. With regard to diet and lifestyle, the most common recommendations that patients receive is essentially drink more water and reduce sodium, and there's not really anything much different than any other form of chronic kidney disease or in the management of any other form of chronic kidney disease. So in my lab, we have been working over 20 years on understanding the molecular mechanisms that underlie the progression of polycystic kidney disease. We're trying to understand what is going wrong, and of course, how we could ultimately interfere with a pharmacological approach. We've been doing this for many years. But more recently, we found different types of interventions that have to do with diet and lifestyle factors. And in particular, we found that diet and lifestyle factors can actually accelerate or worsen the progression of polycystic kidney disease, which would be very important, because if you can change these diet and lifestyle factors, this might affect the disease progression. And in particular, we have found that the sort of an elevated kidney stone risk increases the rate of PKD progression. And the other cloud up here is metabolic disease. So I will talk about both of these and then put it all together into sort of like a more combined approach. So we would call this a conservative approach. So if we're addressing diet and lifestyle approaches, we consider it a conservative approach as opposed to a pharmacological approach. Of course, prevention is preferable to a cure, and first do no harm. Those are kind of important principles that are maybe more consistent with a conservative approach. And a very important concept that I'm hoping to get across is this old saying that probably many people are familiar with. Your genes load the gun, but your lifestyle pulls the trigger. So clearly PKD is a genetic disease. So the genes have loaded the gun, but we think that actually diet and lifestyle factors are very important in essentially pulling the trigger and starting the progression of PKD. All right, so in today's presentation, I have sort of broken it down into 4 different stories. In the first story about microcrystals and our findings there. In the second story, I'll talk about ketosis. And in the number 3 story, I'll bring it to ketosis in human PKD, and we'll tell you something about our human studies. And then in diet story 4, I would like to tell you about the development of a diet and lifestyle management program and of a medical food that we have developed. So first, real quick, a little bit more background on how polycystic kidney disease has been thought to develop. As you may know, patients with PKD actually only have one of 2 of the PKD alleles mutated, and we would consider this a first hit or a germline mutation. And it has long been thought that there will be a second hit somatic random mutation that affects the good allele of let's say the PKD1 gene, and this would then lead to cystic progression. But as a number of investigators have found over the last few years, is that this alone is not enough to start polycystic kidney disease, but that apparently a third hit is required. And this will be a form of renal injury. So once you injure a kidney, then you end up with fast progression. And our question had been for the last few years, what is this injury event that can trigger disease progression? And we would consider it this diet and lifestyle trigger right now. So that's a question mark. Which trigger is relevant in humans? And so here's sort of a little model of how cysts will form. They form out of individual renal tubule epithelial cells that start to proliferate. They form these dilated tubules, which eventually keep on growing and form cysts. And this happens, thousands of times per kidney. And we had investigated many different signaling pathways, such as mTOR and STAT3 signaling that are all activated in this progression here. And had asked, what is this third hit trigger that might start it all? And hypothesized and actually found that it could have something to do with these microcrystals that can form in renal tubules and eventually go on to form kidney stones in humans. So let me tell you about this study, which has already been published a few years ago. So all the data is in this paper, and I'm just going to summarize really briefly the most important findings. So if you consider a normal renal tubule with fluid flow going right through the middle, so this is how a healthy renal tubule would look like. But as you, I'm sure all know, is that the kidney is constantly under stress from solutes that are insoluble or very poorly soluble, and that includes calcium oxalate, calcium phosphate, and uric acid. And they tend to sometimes precipitate and form these microcrystals inside tubule lumens, which can then injure the tubule epithelial cells, and they can cause occlusion. And in humans, this actually happens millions of times per day. So all of us were actually excreting microcrystals all the time. And what has been poorly understood, let me go back for a second, what has been poorly understood before our work is how these microcrystals are actually excreted, eventually how the kidney gets rid of them. And what we discovered is that the kidney has an innate system for essentially triggering tubule dilation. So once there's a microscopic microcrystal here, it triggers activation of the signaling pathway, triggering tubule dilation with the apparent purpose of flushing out these microcrystals. And in a normal kidney, after several days, once the crystals have been eliminated, these signaling pathways are inactivated again, the tubule constricts to its normal diameter, and essentially everything is back to normal. And what we have discovered, however, also is that in PKD, apparently this does not work anymore. The return to normal does not work anymore, and that these dilated tubules can overshoot and form cysts. So in other words, a cyst formation kind of requires a micro-injury event by a microcrystal. Okay, so how does this look like? And this is now, these are animal experiments using different rat models of polycystic kidney disease. So on the left here, we're looking at the what's called the hand rat model. And the readout here is just very simple. The 2 kidney weight as a % of total body weight ratio. So we're just looking at how big do the kidneys become. And you can see that a polycystic kidney is shown in black are much larger than normal wild-type kidneys. But if you challenge the animals with a precursor of oxalate, ethylene glycol, that gets metabolized to oxalate, you can see that the progression is much faster, and we end up with much larger kidneys. And of course, we can look at the kidneys, we can look at kidney sizes and cyst sizes and so on. And in another rat model, in the PCK rat model, we studied here a high phosphate diet. So it's only a doubling the phosphorus intake, and you can see that it causes a much faster progression of the disease and worse polycystic kidney disease in this model. And we could, of course, show that this is due to microcrystals and that we can prevent it as well. So what does this mean for humans? Where does oxalate come from? Where does phosphate burden come from? The oxalate burden, much of it comes actually from the diet. In particular, many plants are very high in oxalate, such as spinach, chard, rhubarb, and dark chocolate, and so on. Phosphate is often very high due to inorganic phosphate food additives in highly processed foods, so that can provide a high burden of phosphate. So I always ask a little quiz. What is the kidney's innate defense against calcium crystal precipitation? And the answer is sometimes surprising. It's actually citrate or citric acid. And that has to do with the property of citrate to be able to chelate calcium in the tubule lumen and prevent the formation of calcium oxalate and calcium phosphate microcrystals. So what we found, and this is now a human study here, what we found in human PKD patients is that the urinary citrate level tends to be low in patients with PKD, so oftentimes they have hypocitraturia. And we also found that it inversely correlates with the progression of polycystic kidney, as shown by the total kidney volume here. So in other words, the lower the urinary citrate levels is, the worse the progression of PKD. And this goes along well with other information in the literature. Patients with PKD often have abnormally low urine pH and low urine citrate levels. They have frequent kidney stones, and those patients with kidney stones also progress faster in their polycystic kidney disease. Another risk factor is hyperuricemia, so high uric acid levels, and gout is also very common in PKD. And those patients with high uric acid levels also progress faster. So what can we do about it? We can actually increase the citrate levels by just simply supplementing citrate in the drinking water or in the food. And we have done this here in a rat model of polycystic kidney disease. So we can treat them with citrate or have them untreated, and you can already see that there's a very big difference. We can quantify, for example, the cystic burden. So the control polycystic kidney animals are shown here with their large kidneys. And if we titer this with increasing citrate treatment, we can see a very strong beneficial effect by simply using citrate. So which dietary factors may worsen PKD progression due to this type of third hit signaling? We think that oxalate is one of the dietary factors that worsen PKD due to the formation of calcium oxalate microcrystals. We think that phosphate is one of the risk factors due to calcium phosphate precipitation. And what about uric acid? So in our original publication, we did not study uric acid, but we have studied it now. And the results are being published soon. And the results were very interesting when we challenge rats, PKD rats, with a uric acid diet. We see a much faster progression of the polycystic kidney disease. So we can look at cystic index, for example, and we can look at cyst numbers. So everything increases and everything worsens. And we can, of course, see uric acid microcrystals forming in these kidneys. So we think that, and of course, serum creatinine goes up, indicating worsening kidney function. So what about humans? So this is from a study that will also be in our paper. So it's not yet published, but the study has been completed, and this was done in collaboration with Dr. Roman Müller at the University of Cologne in Germany, one of our long-term collaborators. They have looked at a large patient cohort of 719 patients and correlated the serum uric acid levels with the height adjusted total kidney volumes. So you can measure the total kidney volume in patients by MRI scanning. And there's a strong association, but one could, of course, say what is the cause and what is the effect here. There's also strong inverse association with the eGFR, the kidney function measure. We were able to do a subgroup analysis and focusing on people with normal kidney function that are still at CKD stage 1 or 2. So it was 443 patients with normal kidney function. And you can see there's still a strong association between serum uric acid levels and total kidney volume, even though those patients actually don't have any disrupted renal function that could cause uric acid accumulation. And then 75 of these patients actually had 3-year follow-up data where we could calculate the change in total kidney volume, so the actual progression of the disease, rate of progression of the disease in a 3-year time window. And there was a very strong correlation with serum uric acid, again, suggesting that high uric acid levels actually predispose to fast progression of polycystic kidney disease. Good. Okay, so we would argue that high uric acid levels are also a risk factor for worse progression of polycystic kidney disease. And so we kind of put this up here under the category of kidney stone risk. So we think a conservative approach would suggest to avoid high oxalate and inorganic phosphate intake with the diet, and exposure to high purine intake, and the risk for high uric acid levels. It would be important to normalize the urine pH, bring it more into alkalinize the urine, normalize the urine citrate levels, and potentially use a plant-focused diet, which is already known to be more alkalinizing. So what about the second cloud up here, metabolic disease? So let me pause on the kidney stone risk for a moment and tell you about our work on metabolic disease, and then I'll get back to the kidney stone risk and put it all together. So in the same year, in 2019, at the end of 2019, we published another paper, this paper here, also by Jacob Torres as the first author, where we found that the metabolic state of ketosis is actually very potent in slowing the progression of polycystic kidney disease. And again, the data are published, but I will just summarize briefly what we found. The basis for this paper is the finding by several different research groups suggesting that PKD is actually a metabolic disease on the cellular level. And investigators have found, including us, that cysts in PKD have defective mitochondria, they have a defect in fatty acid metabolism. They appear to depend on glucose for their energy needs, and they're highly glycolytic. And altogether, this resembles a Warburg-like metabolism that many of you, I'm sure, are familiar with from the cancer research field. So the Warburg effect is well known in cancer cells as well. So what we had done a number of years ago was trying to affect sort of the energy metabolism in PKD mouse model by a really simple approach, by just feeding the mice less food. So we put them on a reduced caloric intake regimen, only 23% food reduction compared to the ad libitum controls. And the results were very surprising to me. I would not have thought that this would work. So you can see here's a normal kidney, a normal mouse kidney, and this is now a PKD1 mouse model. Here's a polycystic mouse kidney of a mouse that is just fed ad libitum, so they have free access to food. And here's the kidney of a mouse with 23% food reduction. So everything else was normal in these mice with reduced food intake, except that the kidneys did not grow as fast, and the progression essentially stopped, the progression of the disease. So we published this paper essentially saying that this works and that we don't really understand the mechanisms why it works. And since then we have evaluated and identified the mechanisms and nailed it down to the metabolic state of ketosis. That turns out to be important. And just a very quick recap, what is ketosis? So ketosis is actually a normal metabolic adaptation to carbohydrate restriction that can occur during fasting or starvation or certain forms of ketogenic metabolic therapy. And the opposite of ketosis is, of course, how most people live their lives typically. And that's shown here, where we typically have high blood glucose levels, and glucose becomes the main energy source for all the organs, tissues, and cells in our body. The excess glucose is converted into triglycerides and deposited in the fat tissue. And this, of course, then leads to obesity over time. If you have persistent hyperglycemia, hyperinsulinemia, and so on. And however, the opposite of that is the metabolic state of ketosis that allows our body to actually mobilize the fat reserves in our adipose tissue, release fatty acids, which then become an energy source for our cells and organs in the body instead of blood glucose. And some of the fatty acids are converted by the liver to ketones, which are also used for energy consumption, especially by the brain and by certain other tissues. And the major ketone, the main ketone that is produced by the liver is called beta-hydroxybutyrate, or BHB. So that became an important player for us. So I'm highlighting it here. So BHB is this main ketone that's made by the liver during ketosis. So I just want to emphasize, because it's often confused, because ketosis sounds very similar to ketoacidosis, but they're really not the same. They're almost like opposite conditions. Ketosis is a physiological, beneficial pathway or mechanism, whereas ketoacidosis, of course, occurs primarily in type 1 diabetics and is a pathological and very dangerous state. And they have very little in common. With dietary intervention, it is essentially impossible to become ketoacidotic. So all you do is you go into ketosis. All right, so how does this look like in animals? So you can do this in mice, for example, very easily. If you put a mice on a once per day feeding schedule, so you feed them here, and you measure the what's called the respiratory exchange ratio, so the whole body metabolic rate, if you will, you can determine whether a mouse is burning carbohydrates or whether the mouse is burning fat. And if you feed them a normal high-carb rodent chow, of course, they start burning carbohydrates. But once they have depleted the glycogen reserves, the mouse will be in ketosis and start burning fat. And then you feed them again. After 24 hours, they go back into carb burning mode and back into ketosis. And you can keep doing this for the entire life of a mouse. And this has been studied, and this is actually beneficial and extends the longevity and health span of mice if they go in and out of ketosis. So a normal ad libitum fed mouse that everybody studies, they would be permanently in carbohydrate burning mode. But you can also use what's called a ketogenic diet, and that's the orange bars or orange dots here. So you can actually force a mouse to be constantly in a fat burning mode. All right, and of course, if you do, if you give them food only once a day, you trigger this pattern of time-restricted feeding. Good. Okay, so what we've studied is several different models of polycystic kidney disease: a mouse model, a rat, and a cat model, and it's shown here what they're called. The mouse and the cat models are actually orthologous models. So the same PKD1 gene is affected in them that is also affected in human patients with polycystic kidney disease. And I'm just going to show a couple of examples of what we've done here. Here we're looking at time-restricted feeding. So the animals, in this case rats, have access to food for only 8 hours in the 24-hour period. And this is compared to ad libitum fed rats that have access to food 24/7. The food is identical between them. It's the same carbohydrate, high carbohydrate, normal rodent chow. And you can see that putting animals on a time-restricted feeding has a very strong beneficial effect on their rate of progression of polycystic kidney disease. So here's the ad libitum, here's the time-restricted, and we can look at every parameter. Cystic area, for example, goes down, fibrosis goes down very dramatically, and everything improves. And this is just simply time-restricted feeding, where the mice spend about half of the day in ketosis. We can also use, as I mentioned, a ketogenic diet, which is a very low carbohydrate, high fat diet. And just to illustrate what a ketogenic diet is, so on the left is sort of the standard American diet, also abbreviated the SAD diet, which is a very high carbohydrate and low fat diet. As you I'm sure all are aware, the sort of the standard American diet has generates about more than 50% of the energy from carbohydrates, sugars, starches, and so on. A little bit from fat and a little bit from protein. And on a ketogenic diet, you essentially flip this around. You restrict the carbohydrates and you provide energy in the form of fat, and you don't actually change the protein intake. So this would be a ketogenic diet, and we have done this with rats again, or of course also with mice and so on. And you can see a very strong beneficial effect. Again, control chow here and a ketogenic diet right here. Both of them are now ad libitum. And the difference is really just the composition of the food. So a very strong beneficial effect of a ketogenic diet. And again, everything improved, including fibrosis, proliferation, cyst growth, and so on. Good. And to our surprise, a ketogenic diet actually even partially reverses existing PKD. So when we study this in older animals, so we start the intervention at postnatal week 8 and carry it through to postnatal week 12, we see that the existing kidney sizes actually decrease while the body mass still increases. And we can look at cystic area, for example, it decreases. So we observe a partial reversal of existing renal cystic disease, which was unheard of until that time. Interestingly, so we asked what happens if you just supplement with the ketone beta-hydroxybutyrate. As I mentioned, that's the main ketone that is normally produced by the liver during ketosis. But you can also give it to animals, treat them with beta-hydroxybutyrate by adding it to the drinking water or to the food. We did this here for 5 weeks, for example. To my great surprise, it was almost completely effective. So you can see a cystic rat kidney here. Here's a normal wild-type control kidney. And this is a cystic rat kidney of a rat that was treated with beta-hydroxybutyrate, and it was almost indistinguishable from a wild-type control kidney. And you can see the data, the quantification here, a very strong effect with just simply BHB alone on top of a regular high-carbohydrate rodent chow. Good. Okay, so the take-home message of this part is that dietary ketosis appears to strongly inhibit PKD progression, and that exogenous beta-hydroxybutyrate that you can treat with mimics the beneficial effect. Of course, a possible clinical translation would be to put patients into nutritional ketosis with ketogenic metabolic therapies such as time-restricted eating, intermittent fasting, ketogenic diets, or by supplementing with beta-hydroxybutyrate. And in the US, BHB is available as a supplement. It's considered as generally recognized as safe. So let's move this into humans with PKD now. So let's see what we can find in humans. Just as some more background here, I think it's always important to remember that we humans today, our genes evolved over millions of years, of course, not only in the last, 100 years, but literally over the millions of years. So whatever diet and lifestyle was common in evolutionary times, that is exactly what our genes have evolved to be optimal. And our ancestors look like this. Today, however, many of us look like that. And this has happened only very recently, only maybe the last 50 years or so, that obesity has become an epidemic. In many countries, in the US, and I'm sure in Mexico it is a problem as well. And many people consider the fact that we are now have switched as a species to a very high carbohydrate diet and lifestyle, and essentially an avoidance of ketosis. So most of us are actually never in ketosis anymore, whereas our ancestors would have been in and out of ketosis all the time. All right, so it's considered that we're metabolically inflexible, and because we're lacking this exposure to ketosis. Okay, so how does this look like in human ADPKD patients? This is a study that was also in our paper, where we're trying to correlate the baseline serum glucose levels of non-diabetic patients with PKD with the average total kidney volume change, so the rate of progression, and there was actually a strong association here, suggesting that patients with higher serum glucose, baseline glucose levels, have higher progression of their polycystic kidney disease. And this is backed up by other investigators in the literature. Hyperglycemia and type 2 diabetes strongly correlate with faster progression of polycystic kidney disease. Obesity and overweight also correlate with faster progression. So we did a retrospective case series study. This was done by a nephrologist in my lab who did 3 years of research in my lab, and we published this paper recently. And just to show you, some of the highlights of this paper, we were able to identify 131 patients with polycystic kidney disease that had already, on their own motivation, experimented with ketogenic diets. Most of them with an actual high-fat, low-carb ketogenic diet, and some with time-restricted feeding. And this was done on by an average duration of 6 months. And as you would expect, these patients lost weight, and so the obese group, became overweight. The overweight group became normal weight, and nobody became underweight. So there was a very strong effect on improving obesity and overweight. We asked the patients, so there was, every patient was subjected to a long questionnaire and a phone interview. And then we collected their health data as well from their doctor's offices. The question was very interesting. What impact did your diet have on your health and well-being? 86% of the study subjects reported that it strongly improved or somewhat improved their health and well-being. So this was a surprisingly strong effect here. When we look at the different symptoms, sort of PKD-related symptoms, such as flank and back pain, fatigue, abdominal fullness, acid reflux, and so on. You can see which of these symptoms ended up improving with the ketogenic metabolic therapy. So pretty much across the board, most symptoms improve in many patients. Then we looked at sort of hard data at blood pressure. Before the ketogenic diet intervention and during the ketogenic diet intervention, you can see a very strong beneficial effect on mitigating hypertension in those patients. And also, we looked at the EGFR values based on creatinine. And there was actually a statistically significant improvement in the EGFR in patients compared before versus after the ketogenic diet intervention. So there are many caveats, of course, to this paper. It's a self-selected group of patients. They were highly motivated and so on. So what we've done since is we've actually completed a prospective randomized controlled trial. And this was done by the group of Roman Müller at the University of Cologne, our long-term collaborator. And really the entire study was done by them. I merely helped with trying to get funding for the study and helping with the study design. The study recruited about 63 patients that were randomized into 3 arms: ketogenic diet arm, an intermittent fasting arm, so 3 days water fasting per month and done for 3 months, and a control arm, so no change in diet. The intervention was for 3 months, so a relatively short period of time. The study has been completed now. It's not yet published, but it's in review, and I would expect it will be published soon. And some of the outcomes were actually very interesting. So feasibility is always a big question in dietary interventions. Interestingly, so on a scale from -4, meaning not feasible at all, to +4, meaning no problem at all, the feasibility was rated around 2 or so for both ketogenic diet and water fasting, which is actually, I think, a pretty good result. The adherence was very high, so patients actually got into ketosis. So this can be measured by with an acetone breath meter or by just blood beta-hydroxybutyrate measurement. And to our surprise, when we looked at the eGFR values as an indicator of kidney function, you can see the control group in the 3 months of the study slightly maybe decreased the eGFR, but surprisingly in the ketogenic diet arm, the eGFR values actually improved. So this was a surprise, and this was actually statistically significant. We also looked, and this was not only based on creatinine-based eGFR, but also on cystatin-based eGFR. So both should essentially the same result. And what we also looked at was total kidney volume, which is sort of the most common readout for efficacy in drug trials for polycystic kidney disease. So it's again done by MRI scanning. And in the control group, the total kidney volumes, slightly increased during the study period. In the ketogenic diet arm, it actually decreased during the study period. This missed statistical significance, so at this point, it is only a trend. But it was, to me at least, very surprising that in such a short period of time, we already see a trend. Good. Okay, so for this cloud up here, metabolic disease, we would suggest that high carbohydrate diets are detrimental in PKD. If somebody is never in ketosis, that is probably a worsening factor. If somebody is overweight and obese or has metabolic syndrome, type 2 diabetes, chronic systemic inflammation, these would all be factors that lead to faster progression of polycystic kidney disease. And then, of course, to mitigate this, one could be on a low carbohydrate diet, be in nutritional ketosis, supplement with exogenous beta-hydroxybutyrate, and of course weight loss would make a lot of sense. So how now I want to bring it to the actual management program that we have helped to develop and medical foods that we have developed. So how can we combine keto and citrate? So I talked to you about the whole ketosis aspect and about the citrate aspect and that addresses the microcrystals. So we wanted to bring this together and essentially combine beta-hydroxybutyrate treatment with citrate treatment. And this shows results from a rat experiment to titrate different combinations of BHB and citrate. And you can see there's actually a very strong effect. This turned out to be a synergistic effect. So meaning that if we combine BHB and citrate, we can actually treat with lower doses of both of them and still have the full beneficial effect. And this then led to the formation of a startup company out of the University of California. It's called Santa Barbara Nutrients. Just full disclosure, I'm the founder and president of Santa Barbara Nutrients and currently serve as the chief scientific officer. And it's really based on the studies from my lab, plus of course from many other labs as well. And we created what's called a medical food called Ketocitra. So in the US, the regulations are a little bit different from Mexico. There's an FDA regulated category called medical foods, which means the ingredients have to be approved food ingredients, which our ingredients are. So it's a medical food for the nutritional management of polycystic kidney disease, made by Santa Barbara Nutrients. It's actually a powder in a jar. This will be a 1 month supply. It's to be dissolved in water, and you drink it twice a day. It delivers exogenous beta-hydroxybutyrate, and you can see the composition here on the right. It also delivers alkaline base, so it has about 51 milliequivalents of alkaline base together with citrate. And this is meant to increase and normalize urine pH and normalize urine citrate levels. It also contains calcium and magnesium that facilitates the absorption or neutralization of oxalate and phosphate from food, so that the patient will have less burden and less stress on the kidneys from calcium oxalate and calcium phosphate. So then we teamed up with very experienced renal dietitians led by Jessiana Saville, and created a dietary management program called Renew, which stands for renal nutrition, and it rhymes with renewing your kidneys, if you will. The features of this program is that it's a ketogenic diet program, so with the goal to decrease blood glucose levels, raise beta-hydroxybutyrate levels, reduce body fat and obesity. It is plant focused, so it's not vegan or vegetarian, but it's a little bit more plant focused than typically a ketogenic diet would be. And this again has the goal to help with urine alkalinization, to lower the purine and uric acid burden. It's a low oxalate program, so it's very carefully designed to avoid high oxalate foods. It also avoids high, foods high in inorganic phosphate food additives, and it incorporates this medical food ketocetra that I just mentioned. The program is a 3-month program. And it's all remote, so patients are are taught how to implement these diet changes in a remote group setting. And we published a paper about this program recently. This is essentially the results of a beta test of the program before it was publicly rolled out. So there were about 24 patients in this beta test. And some of the questionnaires answered questions such as, did the Renew program improve your PKD symptoms? 50% strongly agreed, 39% somewhat agreed, 11% were neutral. Nobody said that it worsened their symptoms. And it was similar for hypertension, but did the program improve your hypertension? So a strong response for improving hypertension, for example. We also saw improvements in kidney function in some of the patients. And an interesting outcome is that many of the patients report improvement in pain levels. And pain is one of the complications that is very common in PKD. So amongst responders here, 56% responded that the Renew program greatly improved the pain levels. 29% said somewhat improved, 15% neutral, and nobody said that it worsened their disease or their pain. We're using the Renew program now as for clinical trials, as a training phase for clinical trials to look at long-term outcomes. To date, over 150 patients have gone through the Renew program, so we already have a lot of data on those patients. So we're putting actually together a retrospective study on those patients that have already gone through it. But we're also planning prospective controlled clinical trials. And there will be done with Dr. York Pei at the University of Toronto in Canada, and Dr. Shigeo Hori at the Juntendo University in Tokyo in Japan, where we will have either 40 or 100 patients plus the same number of controls. And the study essentially uses this the Renew program, which, as I mentioned, is a 3-month program, and then there will be a follow-up up to 1 year. So we're very excited about this program and about the sort of the current feedback and reports that we have gotten from patients so far that have gone through the program and that have been using ketocetra. And I hope to be back sometime to tell you about the results of these clinical trials. So that's it for me right now. Again, here's my lab at UC Santa Barbara. And if we have time left, I'd be more than happy to answer any questions you might have.
Thank you, Dr. Weimbs, for the excellent presentation. And of course, we have around just a few minutes. So let me read the first one. Bueno, agradecerles a todos que continúen aquí. voy a dar lectura a algunas de las preguntas que nos han estado enviando. Okay, the first one, can it be used in people on dialysis? I guess ketosidra?
It's a good question. We don't have a good answer for it because we have not tested this yet. We actually are very interested in testing it, especially well, on dialysis is one thing, but also in transplant patients, for example, to facilitate the health of the transplanted kidneys. One thing we are studying, or we're planning to study, is near end-stage disease PKD patients, that are maybe CKD stage 4. Currently, we recommend ketosidra, for mild to moderate polycystic kidney disease, but a lot of patients are taking it also for more advanced stage kidney disease, and it seems to still help them. So we have some good anecdotal data that patients are able to delay the progression of their polycystic kidney disease, and it gives them more time on a transplant waiting list so that they can line up a transplant before their kidneys fail. So that's something we'd like to study in a clinical trial at the University of Sydney in Australia right now.
Thank you. Another one, will the effect of liquid ketones work the same?
So by liquid ketones, I'm assuming the person asked about not the ketone salts. So ketosidra contains what's called ketone salts, so BHB salts, and it's the potassium, the calcium, and the magnesium salts, and it's a solid. That's why it's a powder. There are liquid versions that are esters. So they're ketone esters, which are essentially chemicals that are a little bit different, and they get broken down in the body into the ketones later on. We have not worked with the esters. There's some disadvantages to the esters. It's very, very expensive. They taste very bad. So many people cannot tolerate the taste. So it costs about 10 times more than what ketosidra would cost. So it's not really affordable. Maybe not necessarily easily obtainable everywhere. And we actually see a lot of advantages of the BHB salts because it allows us to formulate it with alkaline base and so on.
Thank you. How many oxalates are recommended per day?
Yeah, so that's a disputed question. Many practitioners would say limited to 100 milligrams per day. I think that it doesn't hurt to have less than that. I think less is even better. So I think, on the Santa Barbara Nutrients website, for example, we have a long list of the oxalate contents of different foods. So people can just educate themselves to see, how much oxalate is in 100 grams of this food, that food. And I always recommend, keep it low. But of course, you can supplement with a calcium source, which will neutralize the oxalate. And that's actually one point of ketosidra. It contains calcium, which helps to neutralize oxalate and prevents the absorption of it. So if somebody does eat a lot of oxalate in their salad, let's say, as long as they take it with ketosidra, for example, that would probably greatly help reduce the absorption.
Thank you. When the GFR is low, what happens with the prescription of proteins?
Of proteins?
Yes.
Yeah, so that's a big question. It's very controversial. Traditionally, it has been regarded that high proteins might be harmful for kidneys. I think that has been largely debunked, and more recent studies don't really support this anymore. There's even in polycystic kidney disease, there's a somewhat recent study out of the Netherlands showing that protein intake really does not affect the progression of PKD. However, in later stage patients, of course, it can become a problem because the kidneys cannot excrete urea efficiently anymore, and some of the other toxins that are essentially come along with high protein foods. So I think there's definitely a reason to reduce protein intake as patients progress further towards end-stage kidney disease. But for mild to moderate, I don't think there's good data suggesting that protein restriction is indicated.
How often should TKV, I guess total kidney volume, be done?
Well, it depends, of course, on who pays for it. Does the insurance pay for it, and so on. It's in some centers, for example, at the University of Cologne, there every patient gets a TKV done by MRI once per year, which is fantastic. But in normal common practice, it's not so often. I'm not quite sure what to say. I think it's mostly a factor of resources. If somebody can afford it on out of pocket, or if health insurance picks it up.
Does a low-carb diet work the same, or is the ketogenic diet rigorous?
Yeah, it's difficult to say. What we usually recommend is so a ketogenic diet is sort of very difficult to implement for many people, and they need a lot of help. They need dietitians to teach them and keep them on track. It's probably a good idea to start even just with a low-carb diet, especially if somebody is taking Keto-Citra plus a low-carb diet. I think that's probably a really good combination. And people can always work on improving it even more. Maybe start ketosis intermittently, or combine a low-carb diet with a time-restricted regimen and so on. I always think, if you tell a patient to do all these many things all at once, it's very frustrating, and many will fall off the wagon and end up doing nothing. So probably a stepwise approach is probably a good idea. And an easy thing to take is always started with Keto-Citra, and then have this as a baseline and build up on that with diet and lifestyle changes.
Thank you. Will long-term use of citrate have any effect on the ureters?
On the what?
Ureters.
Oh, on the ureters. I wouldn't think so. Citric acid, is very commonly taken by people with recurring kidney stone disease, and usually they have to take it in theory for the rest of their lives. So I'm not aware of any negative consequences there. The one negative consequence oftentimes that people experience with potassium citrate, for example, is gastrointestinal problems, because they don't tolerate it well, especially these large pills with potassium citrate. That's probably a little bit better with something like Keto-Citra. So it seems that people tolerate it much better, and that might have to do with the fact that it's not only potassium citrate, but it is spread out between potassium, calcium, and magnesium. So there's less of everything. It's more of a maybe more tolerable blend. So a lot of patients, I think, can tolerate it much better.
Thank you, doctor. That was actually one of the last questions that we had. I want to thank you again, Dr. Weimbs. I really appreciated your time, and we wish get some new meeting again. So have a good night, Dr. Weimbs, and see you soon.
Great. Thank you, Paula, and thank you everyone for listening. Really appreciate it.
Thank you.
Bye.
Y bueno, para continuar con el proceso para poder adquirir su constancia por asistir a este webinar, Les voy a compartir los pasos. Será necesario que entren al link que les voy a compartir